Yeah, so I am going to be talking about ventricular assist device insertion and anaesthesia around that. And one of the really exciting things about being involved in this type of management is it is a multidisciplinary decision and a multidisciplinary involvement. And I really enjoy the team aspect that comes with all of this. And one of the great things about anaesthesia is we are increasingly becoming perioperative physicians and involved in the decision making very early on in these patients and their management right through the perioperative course. So what I'm going to talk to you about today really is not so much the intraoperative management of these patients, but a lot of the decision making that goes around inserting left ventricular assist devices. I don't have any financial disclosures other than that I'm a Collingwood supporter. But when we talk about the emergence of new technology, I think this is a fantastic sort of slide in terms of what happens in sort of the growing evidence space. And there are lots of known knowns that we know about patients with right ventricular dysfunction and left ventricular dysfunction. There are a hell of a lot of known unknowns, and there are many, many unknown unknowns. And I'm going to sort of try and delineate a few of those for you today. And very simply, just to revisit what a ventricular assist device is, well, basically it's a device used to provide mechanical support for the left ventricle, and the general configuration is that it's inserted in the apex of the left ventricle and allows blood outflow into the aorta, and it's a preload dependent afterload sensitive device. And that's a key statement because ultimately it means that this operation centres around the right ventricle and its management thereof entirely. The two main devices that are seen implanted on the market today are the HeartMate 2 and the HeartWare, and the main difference between them is their flow characteristics, and there are a few other management idiosyncrasies, but I won't bore you with those today. So what do we know about patients getting ventricular assist devices? Well, we know that it's happening more and more and more, and a lot of the data, of course, comes from the US that have a very large database on all of this, but we know that heart transplant rates as a constraint of organ availability are sort of fairly stagnant, but more and more people are getting these devices inserted. And we know that those who do get them tend to do fairly well. The survival with the mechanical device is pretty good in most of the patients that have one inserted, and all this data is from the latest INTERMAX report, who keep a tab on all of this. And we also know that patients who go on to have a transplant, having had a mechanical device inserted, do quite well also. So its role as a bridge to transplant is very, very much validated, and there could be an argument made that in fact insertion of these devices allows for optimisation of these patients prior to them undergoing their transplant procedure. That is, resolution of a lot of end organ dysfunction that's attributable to their left heart disease and their right heart disease, and makes them much better transplant candidates in the long run. And that's a sort of watch this space scenario. And who's getting this support? Well, obviously there's patients with severe end-stage heart failure, and the few characteristics that are involved there. Their left ventricular ejection fraction is significantly poor, generally around 10%. They've often undergone cardiac resynchronization therapy. We know that they've got significant exercise limitation. And the main streams which we engage in, certainly in Australia, are either the bridge to transplant or the bridge to candidacy. The North American experience is that a lot of patients are getting these as destination therapy. That is, they're dying with the device or it's put in because they're not actual viable transplant candidates. The funding for that model does not exist in this country yet. And that said, people do slip between the cracks in terms of the fact that they simply just don't resolve and get to their transplant. So people do die with these devices. It's just not the intended means for which they're inserted. And then there's another sort of subset of patients, the restrictive, the hypertrophic disease and the adult congenital heart disease patients that may have a role for these sort of devices as well. And this is an emerging frontier. And this sort of goes to what I said before in that this classification of bridge to transplant, bridge to destination, etc. is probably invalid now, and really we need to just consider these patients as in who is indicated to have mechanical support and do they have an absence of contraindications, and our decision making should effectively go from there. So there's a lot of merging of those and crossing of the streams. When we should put these devices in is open to debate, and this is a slide based on the INTERMAX criteria of the classifications of 1 through 7, which is basically a degree of severity of the heart failure. And you can see that the bulk of the experience is in patients that are pretty sick, 1, 2 and 3. So they're either inotrope dependent, they're on the slide, or they're critically unwell. But increasingly I think there's implantation of these devices in class 4, and these are patients with resting symptoms, not yet inotrope dependence. And that's probably unique to America in a degree, and that a lot of these patients are for destination therapy. But you could potentially argue that in undertaking this operation in a patient that's essentially well, do you remove some of the morbidity and potential mortality associated with the implantation of these devices in an unwell state? And unfortunately that hasn't quite played out in some of the survival in the literature. Keep in mind that again, this integrates data from destination therapy patients. But by and large, at 12 months, the survival in patients who have undergone the procedure earlier as well as later is more or less the same. But what we do know is that early implantation is associated with significantly less right ventricular dysfunction and the need for institution of mechanical support. And we know that patients that need biventricular mechanical support, by and large, do badly. So I remember when I was a fellow and about to anaesthetise one of my first cases with one of the consultants, and very worried about the multiple sort of things that go on in these sort of events, and he said, "Stuart, don't worry, it's an operation about the right heart. There's a couple of other bits, but really that's all we're about." And he's absolutely right. This is by and large an operation about protection of the right ventricle, and I'll hopefully illustrate that to you today. So what do we know? Well, we know that right ventricular failure after device implantation is a big problem, and it's a consistent and reproducible theme. And some of the morbidity and mortality associated with it include direct death, certainly reduced survival to transplantation. Even those that do go on to get transplanted have significant decreases in their post-transplantation survival. There's a high reoperation rate. There's significant renal failure, ICU length of stay and bleeding. So there's a substantial amount of morbidity associated around all this. And we also know that it's very common. Up to 40% of patients having device insertion have right ventricular dysfunction of a severe nature. There's potential that there's definition bias here, and there's a lot of grading of the definitions of right ventricular dysfunction after this device insertion, but as high as 40% in some cases. And it may be that this is only based on the fact that there's inotrope definitions used for right ventricular dysfunction as opposed to the need for mechanical support. But even so, it's a significant problem. This is the current INTERMACS criteria that defines right heart failure, and basically you notice that they grade it into a scale, and a lot of it is due to the need for inotrope support for a defined period of time. And interestingly, there's no echo-based criteria in this definition, and I think I'm only speculating, but my strong suspicion is that we have no idea what right ventricular failure from a quantification echo perspective looks like in these patients. This is a completely abnormal physiological model. The left ventricle is unloaded in a completely different direction. The ventricular interdependence is lost. There's often significant tricuspid regurgitation. So to actually quantify right ventricular failure in this group from an echo perspective is a real challenge. But you can see that it's a spectrum, and the fact that it is a spectrum is probably important. And this study looked at patients that had right ventricular failure and looked at their severity of management after the operation. They saw that in the less severe group, that was 100% went on to successful orthotopic heart transplant. Those that require more support had a less significant successful experience in their progression, and those that needed right-sided mechanical support had a very, very poor outcome. So it is important that we're able to grade it, that we're able to assess it, and that we're able to quantify it. And this just goes to what is the pathogenesis of right ventricular failure in this subset. And you can see that what an LVAD effectively does is decompress the right ventricle, and that's the crucial part obviously of its management, to give the left ventricle a rest. And what it does is change the septum dynamics substantially and brings the septum over to the midline generally, also altering the mechanics of the right ventricle. It increases the cardiac output and increases the volume load that the right ventricle has to deal with. And this schema sort of illustrates that in terms of decreasing the wedge pressure by decompressing the ventricle, some offloading of the pulmonary vascular resistance and decreasing the right ventricular work. But it can also induce failure, and it does that by increasing the venous return, so it subjects the right ventricle to significantly higher volume load, potentially increases the amount of tricuspid regurgitation, and combine that with the mechanical disadvantage of the alteration of the septal position. This can be a bit of a vicious spiral for the right ventricle to have to endure, particularly those that aren't trained. And there's no doubt that that's exacerbated in moderate to severe right ventricular impairment starting from the get-go. So what do we know? Well, we know that RV failure is bad, and we know that it's common, and we know that it's a barrier to achieving heart transplantation, which in this country is the predominant reason that we're inserting these devices. And we also know that it's a spectrum of disease. But what we don't know is, can we actually predict it? And can the severity of how bad it is be predicted? And if we can predict it, can we actually do anything significant about it? So in the preoperative prediction, well, there's a lot of associated factors and a number of studies, there should be a number of studies coming up there, but basically there's about 10 or 12 different studies that have looked into this substantially, and all they've come up with basically is a number of discrete risk factors which are not particularly predictive that have all been amalgamated in this table. And you can see there that effectively all they tend to suggest is that the patient who is more unwell with worse RV dysfunction having end organ dysfunction attributable to their right ventricular impairment tend to do worse. But as I say, they're inconsistent and they're not predictive. They're just associations. So a number of people looked at predicting the potential for right ventricular failure after the insertion of a mechanical device, and there are a number of risk scores that were devised generally through single centre experiences, one of which Julie mentioned before in the Michigan score, and that did gain some traction certainly in research literature and probably in clinical practice as well as a predictor, but the sensitivity was still fairly low. More recently, the CRIT score has been devised, which has some increased utility, particularly as it's got a good negative predictive value, but still there's no great overriding score that we can use to predict this. And why is that? Well, a lot of this was retrospective derivation, the heterogeneity in terms of the patient population and the device that was inserted. So we've gone through the emergence of technology here where we originally were implanting pulsatile devices and are now implanting continuous flow devices, and all this data is sort of in the mix. And there's been generally disappointing results when single centre validation's been attempted with all these risk scores. So RV failure etiology is also multifactorial, and that's a key component of all of this. This is some of the echo criteria which people have used to potentially predict or at least advocate that there may be an issue with the right ventricle after implantation of the left ventricular assist device. And generally there's been conflicting evidence for most of the parameters that are illustrated in the table. TAPSE has shown promise and been refuted in multiple studies. The 2D parameters similarly. Tissue Doppler had caught favour for a while, but is susceptible to multiple measurement errors, etc., as we've heard from previous speakers. But the one that has gained traction to a degree, and Julie touched on that before, is right ventricular strain in the preoperative period. And it tends to provide that more direct assessment of contractility in these patients and may have some utility, but still the evidence isn't there. So what are we left with in terms of prediction? Well, some people added some echo scores, as Julie said before, to the Michigan score and saw that strain was incremental in its predictive value. And there's a new criteria called the right ventricular load adaptation index, which also shows some promise. But are we there yet? Definitely not. So no single parameter in isolation is useful. And we can safely say that patients with worse right ventricular function in the pre-op period are at high risk, but beyond saying much more than that is a real challenge. It's imperfect and there's no discrimination for severity, so we can't say this patient might have mild RV dysfunction as opposed to, severe RV dysfunction. And what are the implications in management of that? And does it actually matter? It's all very well to predict all this stuff, but can we actually do anything about it? So I'm going to talk a little bit about some of the potential for surgical intervention and medical intervention, that is optimising the patient prior to the left ventricular assist device and the intraoperative management. So severe TR has been repeatedly identified as a risk factor, and does actually fixing the tricuspid valve intraoperatively make a difference to these patients? Should we be embarking on tricuspid valve repair in patients having left ventricular assist device inserted? This is a recommendation from the International Society of Heart and Lung Transplantation when mechanical support is implemented, and you see that it's a Class 2A recommendation that moderate or greater tricuspid regurgitation should prompt consideration of surgical repair at the time of implant with a level of evidence of C. And what are the unknowns in relation to tricuspid valve interpretation? Well, there are a hell of a lot in terms of what the literature consists of. There are multiple studies and there's significant patient-device heterogeneity. There's certainly some evidence of harm, i.e. it may impact the patient in terms of longer length of ICU stay, blood product requirement, etc. And there's some evidence of benefit that it may actually protect the right ventricle. This is an article published recently in Circulation, and it had this to say on the modification of the tricuspid valve. It said the single centre studies are provocative, but do not provide definitive guidelines about the effectiveness of concomitant tricuspid valve repair. And they suggest that it provides salient benefits in patients with moderate to severe TR having long-term VAD support. But they say that if the VAD can be used as partial support, lower speeds could be helpful to prevent that derangement and the mechanical disadvantage of the right ventricle, to lessen the severity of the tricuspid regurgitation and then potentially obviate the need for repair. So not entirely clear as to what we should do. And this is a recent meta-analysis looking at the intervention of the tricuspid valve with respect to a couple of different outcomes. Basically, it pooled the evidence of 6 studies, but again, significant heterogeneity amongst the group in terms of the severity of the tricuspid regurgitation, the intention that left ventricular assist devices were inserted with, and the patient population. and it largely undertook tricuspid valve repair. But you can see that both in the need for implementation of a right ventricular assist device and in mortality, there was no difference between the two groups in terms of tricuspid valve intervention. So the conclusion was that it created a longer bypass time, but there was no difference in the outcome data, but they made the statement that the baseline risk was not adjusted for. Two other papers which are fairly recent have come out looking at tricuspid valve repair, and they propensity scored adjusted the analysis of the clinical outcome. They also found no difference between right ventricular failure, and also a recent evaluation of the INTERMAX data found that there was no improved survival and that it was actually prone to late failure, with near equivalent incidence of the recurrence of tricuspid regurgitation after its repair. So what does that say? Well, is this actually my patient? Is any of this data applicable to the patient on the table having their left ventricular assist device as a bridge to transplant? And I think we can potentially only know more as time goes on. The decision around this is certainly not entirely clear. So just to talk a little bit about the intraoperative or perioperative management, and there's no strong signal that preoperative optimisation is actually preventative for right ventricular dysfunction. And there's no such thing at the end of an anaesthetic and a pump run as graded therapy. Even if they are at low risk of right ventricular failure, the anaesthetist is still going to be doing everything in their power to provide optimal conditions for the right ventricle to function at the time of the commencement of the left ventricular assist device and the weaning from bypass. And some of the preoperative things that have been looked at include the right heart catheterisation, which is something that I must say I do pay a little bit of attention to in these patients coming to theatre, particularly the transpulmonary gradient and the relationship to the right ventricular dysfunction. And if I've got a patient that has severe RV dysfunction but reasonable PA pressures and a high TPG, they do make me a little bit nervous in that they have significant potential pulmonary hypertension that's not related to their left heart failure, but also somewhat reassuringly, that ventricle may actually be trained in that it's been used to dealing with high pressures for a period of time. And this is completely objective. There's no evidence or science around all of that. We certainly endeavour to normalise their clotting prior to them coming to theatre, or certainly on the day of, to avoid significant blood product administration. And Chong spoke about the dynamic relationship with volume loading in these patients and right ventricular dysfunction. So we certainly want to avoid having to overload the right ventricle. There's a bit of discussion currently about beta blockade and what we should be doing about its implementation or withdrawal, and we certainly want to offload the volume prior to them coming to theatre, that is reduce their CVP to less than 15. They're obviously certainly going to get aggressive use of inotropes to help the right heart. They'll get inhaled nitric oxide for afterload reduction. But the big question stems around when to institute mechanical right ventricular support, and the discussion around that, as I said at the introduction, was are we actually going to potentially consign these patients to a lower risk, lower level of survival and a lower chance of transplantation, and that's not a small decision. So the prediction of it is helpful. But what I want to do effectively in the operating theatre is optimise the right ventricular function and optimise the septal dynamics, and we tend to use the mid-esophageal four-chamber view and attain septal centralisation effectively in conjunction with a variety of other hemodynamic parameters. And I hate to fly in the face of what the bulk of the meeting has been about, and that quantification of the right ventricle has been important, but it sort of is a bit of a thing about it looks okay in this type of scenario, because we do not have, as Chong has said, any good intraoperative quantification to say that the right ventricle is firing as it should and that this will see the patient through. And it's a perfect storm basically when you come off bypass to set the right ventricle up to fail. There's significant volume overload with fluid administration, the mechanical disadvantage of the VAD. There's obviously PVR issues because the patient hasn't been ventilated for a period, the lungs are going on and off to allow the surgeon's access, the CO2 is climbing, there's potential for hypoxia. So this is the worst that the right ventricle will ever have to deal with in its life. And obviously the presence of tricuspid regurgitation, which in this setting is a dynamic phenomenon. So there are many unknowns, and I tend to classify RV failure in the immediate post-operative period as hyperacute, acute or subacute. And the hyperacute is immediately on separation from bypass. And these are things that tend to be fairly amenable to treatment. That is arrhythmia. There potentially is ischemia from intracoronary air, which will resolve with time. There may be issues with the left ventricular assist device balance with the RV, and there may be valvular issues, which I haven't talked about. But most of those things we can deal with and manage pretty quickly. In the acute phase, which tends to be in theatre, they tend to be related to volume, they tend to be related to PVR or valve issues, or sometimes we just don't know. Sometimes the RV just fails and there's really actually no meaningful reason that we can work out as to why that's happened. But what I want to avoid, and what I hopefully don't want to take the patient back to ICU with, is the threat of subacute failure, which can be due to any of the above, but it's going to constitute the need to emergently implement right-sided mechanical support. And that we know is associated with poor outcomes for these patients. So we know that late emergent salvage support is bad. And the question for me in the operative phase is, how far along this cliff are we going to walk before we say this patient is sort of okay, or they're not okay and we need to implement right-sided support? So from a hierarchy of failure sort of view, it's very, very objective, but basically they've either got no right ventricular function, that is, everything looks good, the hemodynamics look great, their inotrope support's minimal, their end organ function's sort of okay. These are the patients we can take back to ICU and have a good sleep with that night. If they've got some right ventricular failure but it's stable, that is, the inotropes are high-ish but they're stable, everything looks like it's ticking over okay, they're the patients that we can take back to ICU as well. If they've got some right ventricular failure but it's fluctuating, this is certainly a watch and wait scenario, and we'll happily sit in the operating theatre for an hour or two before we actually make a decision regarding these patients. And if it's significant, they split between the two. Do we watch and wait, or do we implement mechanical support? And obviously if they've got declared right ventricular failure, then it's mandated that mechanical support's implemented. But the sum but fluctuating patient is extremely hard to quantify, and that decision to implement mechanical support is extremely significant for their outcome. And I sort of I straw polled my other colleagues about various parameters and things that they use to pigeonhole these patients or to guide them in decisions, and there are a variety of different performance indicators, none of which are validated by research, but are just basically about a general feel and about a general vibe. And they look at right ventricular performance, they look at echo, they look at inotrope requirements, hemodynamic parameters, end organ parameters, and of course the interrelationship between how the right ventricle is working with the left ventricular assist device and the presence of suction events. And it's generally just a general trend of progress. So it's just about the vibe. So the mechanical support, what is the signal in the evidence? Well, we know that an elective VAD probably offers better long-term survival compared with emergency implantation. We know that an early VAD probably offers improved survival to transplant, but may offer reduced survival post-transplant. And we know that RVAD implantation is an independent predictor of mortality in patients as a bridge to transplant. But is there a role for a temporary VAD, that is percutaneously inserted briefly to allow the right ventricle to recover? And there's been a couple of promising studies in this area, but some show that planned intervention is safe and has a high rate of weaning, and potentially there's a role for electively putting these in patients undergoing left ventricular assist device support, and that's an area that we need to watch. So just to conclude, there's an increasing requirement for mechanical support of the left ventricle. Right ventricular failure is extremely difficult to predict. There are multiple associated factors, but no risk score gives an overall picture. And right ventricular failure, of course, has multifactorial etiology. It's a spectrum of disease. There are medical and surgical strategies to prevent right ventricular failure, but none are particularly well supported in the evidence. And diagnosing post-LVAD implantation right ventricular failure is really challenging in the post-bypass phase. And while right-sided mechanical support may suggest a poor prognosis, there could be a signal that early or elective implantation offers some benefit. Thank you.